intracerebral hematoma evacuation.
Hello. Good evening, everyone. My name is Petra. I'm from Universitas Pelita Harapan and a member of the team of neurosurgeon in Indonesia. So I want to share this because it's of particular importance for me, because it's something that can be done in many hospitals. So of course, intracerebral hematoma and intraventricular hematoma is still a big problem. And with new emerging endoscopic techniques, it's easier and can bring better result if we do it via endoscopy. So there has been many studies comparing between craniotomy, decompressive, and minimally invasive ICH evacuation, and we have established it's not inferior to other methods. And instead of doing it the old-fashioned way with the big craniotomy and damaging brain, we can just insert an endoscopic sheath and have a very minimal invasive surgery for these patients. So, which is the best? Many studies have said that the candidates for the surgery is same for standard evacuation of hematoma, but there are different techniques between the scuba techniques and technique by Taiwanese and Japanese neurosurgeons. So what we did and what we want to take away is that we have some key points that it can be reproducible in any hospital, does not require navigation, with basic equipment, and with the most takeaway of confidence in bleeding control, and followed by CSF diversion as required. So our technique is we have a nice trajectory planning, just following the long axis of the hematoma, whether supratentorial or infratentorial. With intraventricular hemorrhage as well, we just follow the long axis of the hematoma so that we can have a maximum evacuation with less damage to the cerebral parenchyma. Our equipment, we use a cerebral corridor creator, so it creates a nice corridor for the endoscope and the neuroport to come in. We use a 0-degree endoscope and a semi-rigid suction minimum of 8 French diameter. Otherwise, it will be too small to suck the hematoma. Now, what we do for bleeding control, so we always like to perform cautery when possible. For example, in this case, when we see a very obvious artery, we do bleeding control with monopolar or bipolar, as we can see in this video. However, there are many times when the bleeding vessel cannot be identified and it's just oozing. So in that case, we do a origami technique. We fold a collagen sheet and then we just insert it. And with some water, it will expand and put a nice pressure on the hematoma, and it will stop the hematoma. And we prefer this instead of the waiting and irrigation method of other authors, because in this way, we can be very confident that the hematoma is resolved. So it provides adequate decompression and with good result, mostly on the older data set, and with 35 cc ICH volume. And the complication is usually a small amount of rebleeding. And we did suddenly find an aneurysm in one case with 20% mortality in these other pathologies. So the key points is it's quick and non-inferior, and the functional outcome is similar, and hopefully will be shared with other young neurosurgeons. Thank you very much for your attention.
Thank you very much.
Thank you very much. Can I please